Hello everyone, welcome to Chapter 5, Anxiety and Obsessive Compulsive and Related Disorders. We're going to take a quick look at some of the highlights in this lecture, but it won't be as in-depth because we dove into some of this material in class this week. Here's our quick overview. First looking at understanding anxiety disorders, then looking at some specific disorders, and then having a discussion at the end around future trends and directions. Anxiety is a fundamental human emotion. It produces bodily reactions or physiological reactivity to prepare our bodies for fight, flight, or freeze, which is that survival response. Anxiety is an anticipatory emotion. This means that the event or situation has not yet occurred. However, the anxiety around that is present prior to it occurring. Anxiety disorders are about unfounded fear. They produce clinically significant distress, and symptoms interfere with an individual's day-to-day functioning. Go ahead and rewatch this video if you'd like to. It gives some examples about what anxiety feels like and gives a comparison to anxiety feeling like a panic alarm going off. Here we see a slide about prevalence and lifetime morbidity of the risk of anxiety disorders in the U.S. Here we see a reminder about the multi-path model. The most important piece about the multi-path model is to note that in general, single etiological models, whether we're just looking at the biological, psychological, social, or sociocultural components, do not adequately explain why people vary in our responses to fearful situations. There are oftentimes numerous factors that interplay to contribute to our fear response involving anxiety, and we want to keep all of those dimensions in mind when we are taking a look at anxiety disorders. Some of the pieces that are in the biological dimension that we will talk about and have talked about a little bit already is the overactive fear circuitry, genotype variations, and reduced serotonin activity. We know that serotonin is the neurotransmitter that has the greatest influence on mood and anxiety disorders. When we are looking at the biological dimension, we also want to rule out any medical or physical causes of anxiety. And this is important because oftentimes anxiety can feel and look a lot like other medical concerns such as hypothyroidism, cardiac arrhythmias, asthma, use of stimulants, or even withdrawal from alcohol. About the fear circuitry in the brain, we spoke about how the amygdala plays a central role. Remember, the amygdala plays a central role in alerting that threat response. It triggers that fight, flight, or freeze response, which is activated after the amygdala triggers the HPA axis. And at the same time, we also know that a second slower pathway is also activated when the fight, flight, or freeze response is activated. And that other response sends a signal to the hippocampus and the prefrontal cortex, but that second response is much slower than the response triggered by the amygdala and the HPA axis. Genetic influences. So again, here we have serotonin. Serotonin is the neurotransmitter that has the greatest influence on our mood and anxiety. And we talked a little bit in class about the polymorphic variation, the 5-HT-TLPR gene that is associated with increased vulnerability for anxiety disorders when you have the two short alleles. Here we have a reminder about the neuroanatomical basis for panic and anxiety disorders. We have how the amygdala interacts with the HPA axis, the hippocampus, and the prefrontal cortex. There are key interactions between biological and environmental influences. We spent some time talking about the study in class of how even when children had the two short alleles, which put them at greater risk, if they were not raised in a stressful, chaotic environment, they were less likely to experience anxiety later in life. And so there is that behavioral inhibition that occurs when environmental factors interact with genetic predisposition. We're going to take a quick look here at psychological and social, sociocultural dimensions. Psychological characteristics can interact with the biological predispositions. We've been talking about that. A key here is the idea of negative appraisal, which is interpreting events as threatening. And in order to address negative appraisal, we would use the skill of reappraisal. So minimizing negative responses by looking at a situation from various perspectives. Oftentimes anxiety or other trauma responses and disorders, we get trapped in feeling stuck in black or white thinking, or get trapped in a mental filter of only seeing the negatives and not also seeing the positives or the strengths. And so that is a little bit of shifting from the negative appraisal to the reappraisal. And there are lots of components that interact with that, both not just psychological, but how biological influences and social influences interact with even this concept of negative appraisal. Social and sociocultural dimensions of anxiety. Daily environmental stress can produce anxiety. Lots of factors contribute to being a risk factor for developing anxiety. Some of the key risk factors include poverty, traumatic events, and adverse childhood experiences, adverse working conditions, limited social supports, and acculturation stress. Here, I referenced this in class, but this is going to be a key table for you to refer back to. It's in your study guide as well. Refer back to this. They have great information about some of the key criteria for these disorders that we're going to spend some time talking about, the prevalence of these disorders, and age of onset for the disorders. We'll see that social anxiety and specific phobias have a typical onset of childhood or early adolescence, and mid-teens for social anxiety disorder, so typical age of onset in adolescence. And then agoraphobia and panic disorder have typical onset later in adolescence, and general anxiety disorder has a little bit later of an onset, more so in our 30s. However, they do have a wide range of onset for general anxiety disorders. Okay, social anxiety disorder, which can be abbreviated as SAD, refers to, sometimes referred to as social phobia, involves an intense fear of being scrutinized or of doing something embarrassing or humiliating in the presence of others. And it often influences how an individual then interacts in social situations or engages in social situations. Social anxiety disorder is often comorbid with major depressive disorders, substance use disorders, and suicidal thoughts or attempts. Women are twice as likely as men to have social anxiety disorder, and social anxiety disorder can be chronic and disabling. So a key that we see here with social anxiety disorder is that it increases when we have social anxiety disorder or experience social anxiety disorder. It increases our risk for anxiety, mood, and other substance use disorders. Phobias. These are specific, strong, persistent, unwarranted fears related to a specific object or situation. There is a great table, Table 5.2, that gives examples of phobias, all the way from what we would call a phobia for fear of heights to fear of strangers or being alone or germs. And go ahead and take a look at that table. Again, Table 5.2, examples of phobias. Phobias are the most common mental health disorder in the United States. A specific phobia is an extreme fear of a specific object or situation. Primary types might be a fear of spiders or heights, and again, refer to Table 5.2 to see the names that are associated with these specific phobias. Agoraphobia is an intense fear of at least two of the following. So being outside of the home alone, traveling via public transportation, being in open spaces, being in stores or theaters, or standing in line or being in a crowd. Situations are feared because escape or help may not be readily available. Others may experience this, slightly different from where this fear comes from or how they experience the fear. But a key here is that you must have an intense fear of at least two of those following that we just went over in the list. And a common treatment for agoraphobia would be exposure therapy. Here we have age of onset for different phobias. We see animals have a lower age of onset all the way up to social situations, closed spaces, and crowds have the latest onset. And a lot of that has to do, again, with how these dimensions interact with each other. So how social and sociocultural and psychological dimensions interact with each other later in life. Have a lot to do with the age of onset for phobias. All phobia subtypes have moderate genetic contribution. There are lots of different perspectives regarding the psychological dimension of phobias and the causes. And each psychological perspective will have a little bit of a different understanding of how phobias are developed based on their theoretical model. Here we have the multipath model of phobias. A key, again, is just to acknowledge and remember that the dimensions interact with one another and combine in different ways to result in a phobia. Some key facts that our text talks about is that 3.5% of Americans have severe injection phobia. 50% of individuals who use medications that require self-injections are unable to perform those injections. And those with an injection phobia fear pain or have unrealistic thoughts, such as the needle may break off. And so that's just some of the fun facts about injection phobias. All right, we're going to take a look now at the social dimension, and then we'll take a look at the sociocultural dimension. Parental behaviors influence development of social anxiety in children. So how overprotection or lack of support for independence, punitive parenting style may influence development of social anxiety in children, because we're reinforcing their concept of safety or lack of safety. Negative family interactions and family stress is associated with social anxiety in middle childhood. Females are more likely to have phobias. Social anxiety disorder is more common in collectivistic cultures. And social anxiety disorder expression differs among cultures. Treatment of phobias. So benzodiazepines can be used to treat phobias. A downside to using benzodiazepines to treat phobias is that it can produce dependence on the medication. Some examples of benzos would be Ativan, Xanax, or Valium, and really those medications are not made to be taken or prescribed for long-term prescriptions. And so when they are taken a bit longer term, if they can produce dependence, they could even produce dependence quite quicker than that. And typically what happens is when the individual is not taking the benzodiazepine any longer, they don't experience the same relief of symptoms for their social anxiety disorder. SSRIs are also commonly prescribed to treat chronic forms of anxiety, and then sometimes beta blockers may be used as well. Cognitive behavioral treatments, exposure therapy is a key therapy. I talked earlier about how exposure therapy would be a key therapy used to treat agoraphobia. Systematic desensitization also uses exposure techniques in a combination with relaxation interventions, cognitive restructuring, and modeling therapy. And these may not exist all separate from each other. The therapist might use kind of an integrated approach, and it will depend on the individual's situation, and it will also certainly depend on their trauma history and how significant that trauma is connected to the anxiety, what the therapy would look like. Panic disorder. So panic disorder is recurrent, unexpected panic attacks. So combined with apprehension about having another attack or behavior changes designed to avoid or prevent having another attack. And these reactions are present for 1 month or more. In a 1-year period, the prevalence rate of panic disorders in the US is about 2.7%. And they are twice as common in women than in men. Panic attacks are very common, but panic disorder, which is what we're talking about here, is pretty rare because you have to meet this really specific criteria for 1 month or more. So again, panic attacks are common, but panic disorder is not as common, pretty rare. Panic disorder, again, we're going to take a look at the biological and psychological dimension and how those interact. Individuals show heightened fear responses to bodily sensations. And we do know that individuals with panic disorders have been shown to have fewer serotonin receptors. And so here again, we see the role that the serotonin neurotransmitter plays in influencing anxiety. The multi-path model, again here, how all of the different dimensions interact in order to result in the experience of a panic disorder. Right? So maybe we have some biological predisposition, and then maybe we experience something in our social environment related to an anxiety related situation in our social environment. We may also have some psychological predisposition around kind of sensitivity or hypervigilance of safety. And then maybe we are more likely because of gender differences or other sociocultural dimensions. So an example of this, I worked with an individual, a woman, and she had experienced some frequent negative social interactions at work. She had also had some stressors in her relationship with her sister and her parents. She had had some trauma history. So she had that kind of hypervigilance or sensitivity already to the anxiety as well as I'm guessing some, biological predisposition related to genetic factors, although I don't, we can't be sure of that for sure. But definitely she had that increased reactivity, I'm guessing, with her kind of threat response with the amygdala and HPA axis. And so all of those things together not only led to frequent panic attacks for her, but she did develop panic disorder because she met those really specific criteria of being fearful of having another panic attack because of how overwhelming that was for her in social situations, and then changing her behavior in order to avoid having another panic attack, and especially avoid having it in a social situation. And this persisted for quite a few months consecutively, and had really significant impact on her wellness and her daily behavior. And so she was one of the rare cases that did develop panic disorder. And we used a variety of methods of cognitive restructuring and some exposure therapy to work toward not full recovery, but being able to engage more meaningful in daily activities for her. All right, so here we talk a little bit about the role of cognitions in panic attacks, and we may go a little bit deeper into this in class later this week. Sociocultural dimensions, we talked a little bit about how adverse childhood experiences or stressful childhood could impact that, and how women are more likely to experience panic disorder than men. Again, we have a look at biological treatment of panic disorders. Key here is that with most of these medications, there's a high rate of relapse after you stop the medication. And so really important to also combine that with some kind of psychotherapy in order to have more sustainable results. Some types of cognitive behavioral treatment that have been shown to be effective in treating panic disorders. We've been talking about some of those already. And it is a balance between supporting the client and challenging the client in order to help them address that fear response appropriately. Okay, we're going to take a look here at generalized anxiety disorder. Generalized anxiety disorder is characterized by persistent, high levels of anxiety and excessive, hard to control worry over a wide range of life circumstances. So symptoms have to be present on majority of days for 6 months or more, and have to cause significant clinically significant impairment. DSM-5 has lots of specific criteria that you would have to meet in order to be diagnosed with generalized anxiety disorder. But worry is that key characteristic of generalized anxiety disorder. Typically, generalized anxiety disorder develops gradually, beginning maybe in childhood and adolescence. And in any given year, about 1.2 to about 3% of the population is affected by general anxiety disorder. Again, here we see that women are twice as likely to receive this diagnosis as compared to men. And we know based on our conversations in class that doesn't necessarily mean that women experience this at a higher rate. That's what's captured by the diagnosis and by what individuals are reporting, maybe based on social or sociocultural factors and how that influences help-seeking behaviors across genders. Again, we see the interplay of the biological, psychological, social, and sociocultural dimensions as it relates to what causes generalized anxiety disorder. We see that played out here, again, in our multi-path model. And some key, again, common theme that we're seeing here, some key contributors related from that social and social cultural dimension is stressful conditions such as poverty, poor housing, prejudice or discrimination, racism, all contribute to bullying, all contribute to developing generalized anxiety disorder. This disorder is twice as prevalent among those with low income and frequently seen in individuals who may have experienced a separation, divorce, or be widowed, or maybe unemployed as well. And actually, in the case that I talked about earlier, that woman hit a lot of these risk factors in the social and social cultural dimensions. You know, she was a female. She had endured many stressful situations. She didn't have stable housing. At the time, she had experienced some discrimination around weight, and she was lower income and unemployed. All right. Psychological dimension, two keys here are generalized anxiety is about worry, and it's about constantly thinking about those what if situations. It's about worrying. Um, and there are some cognitive models that believe that negative schemas, so a schema is a mental framework for how we interpret or organize information, influence kind of how we see the world, our worldview. All right, I already spent some time when we were on the multipath model talking about social and sociocultural dimensions. Here we have again some treatment for generalized anxiety disorder. Again, you see some of those same common medications along with cognitive behavioral therapy. And now we're going to end here about obsessive compulsive and related disorders. Obsessive compulsive disorder is characterized by consistent anxiety producing thoughts or images and an overwhelming need to engage in activities or mental acts to counteract anxiety or prevent occurrence of a dreaded event. Hoarding disorder is another type of obsessive compulsive disorder. There's the inability to discard items regardless of their value because of those thoughts and beliefs that are associated with the meaning of those items. Here we have some clinical examples of types of an obsession or a compulsion. You can refer back to that in your text if you'd like to. You'll also want to look at table 5.4, obsessive compulsive spectrum disorders. And this is table 5.5. Some common obsessions would be around contamination, and I am sure we'll see this skyrocket or at least increase as it relates to the global pandemic and COVID. Other obsessions are around harm or exactness, so maybe a certain number of times of needing to do something, of washing one's hands, or opening a door or locking a door would be about exactness. And then compulsions, checking, cleaning, or repeating, and so needing to recheck that something is turned off, that the lights are off, that the doors are locked, or cleaning or washing, and then repetitive behaviors are some common obsessions and compulsions. Here we have other types of OCD related behaviors. Again, this is from table 5.4. Body dysmorphic disorder, hair pulling disorder, skin picking disorder. And what do we know about the cause of or where obsessive compulsive and related disorders come from? Heredity is definitely involved. There's increased metabolic activity in the frontal lobe or left hemisphere of the brain for individuals that have obsessive compulsive or related disorders. We see here the multipath model, again, how these different dimensions interplay. Psychological dimensions is related to some of the cognitive characteristics and behavioral perspective of how when we continuously engage in these behaviors, it does then innately reduce the individual's anxiety, and so that creates a reinforcing cycle of engaging in the behavior to reduce that anxiety. Social and sociocultural dimensions. Again, we see the impact of parenting and how that may lead to some of these symptom development and how culture may influence symptom development. Treatments. SSRIs are commonly used. However, only about 60% of individuals respond to SSRIs as treatments. And now we are going to end with a quick discussion about contemporary trends and future directions. Really, a key here is that there are novel methods and approaches to treating anxiety disorders, and specialized therapy programs targeting specific disorders, treatment protocols that can be used across multiple anxiety disorders, and some key technology in order to help with tracking and doing some of that daily tracking and behavior change related to using CBT measures. We talked a lot about CBT, cognitive behavioral therapy, and how it is an evidence-based approach to treat anxiety disorders. It most definitely is, and there's lots of evidence to support that. And there are lots of other therapeutic approaches that are also used frequently and may be effective, but maybe are not as well researched or not as easily researched as cognitive behavioral therapy. And here we have our reflection and review questions. Thinking about phobias, what contributes to their development, panic disorder, generalized anxiety disorder. Go ahead and take a look at these questions, but where you'll find will be most useful to spend your time is looking at Chapter 5 study guide and take a look at those key keywords and definitions, and then also the areas of review. And so again, in the study guide for Chapter 5, take a look at those key definitions and take a look at the areas of review after listening to this PowerPoint. And I hope you guys are all having a great week, and I will see you later. Bye-bye.